Welcome to the Journal of the American Society of Nephrology March podcast. I'm Josie Briggs, editor-in-chief of the journal. My guest today is David Charytan. Dr. Charytan is chief of the nephrology division at NYU. He's a regular contributor to Jason and See Jason. David, thanks for joining us for this conversation.
Oh, I'm very glad to be here. Thanks for having me.
You've thought a lot about prediction scores in CKD, and this is an important topic for our listeners. Our listeners, and in fact, Jason readers all are aware of the very heavy burden of cardiovascular disease faced by kidney patients, but a lot of us are uncertain when and how to intervene. A good predictive algorithm might help. In the March issue of Jason, you contributed a superb editorial, Cardiovascular Risk Prediction Scores in CKD. What are we missing? It's a great title, by the way.
Thank you. I thought it was important to emphasize, what we've done and some of the limitations of where we are.
Yeah, why is this particularly important for kidney patients, cardiovascular disease prediction?
Well, I think that many of your readers will be aware that there's a really high burden of cardiovascular disease, both coronary atherosclerosis and disease that occurs in the myocardium and in the brain. And peripherally, but there's a really high burden, probably accelerated progression in this setting of kidney disease for a variety of reasons, which we are beginning to understand. In that setting, I think it's really important for us to be able to identify the patients who are most going to benefit from treatment. Particularly in light of potential complications of treatment, cost of treatment, burden of treatment when it's unnecessary. So, being able to better identify the patients who need preventative therapy and equally important who are likely to benefit, can really improve treatment.
Right. Cardiology seemed to be a little ahead of us in the prediction arena. And in fact, cardiovascular risk prediction approaches, I think, are reasonably well integrated into care. I know my internist pulls up some numbers. What is the current standard for cardiovascular risk prediction? And how is it actually being used?
So the current standard of care, I think, depends on exactly, which guideline body referred to, but the American Heart Association, for example, recommends using a risk prediction tool roughly every 10 years, something like the Framingham score. The American College of Cardiology has developed the pulled chain equations, which are referred to in this paper. But they're used, for example, to decide when to start therapies like statins or aspirin and beta blockers. Aspirin may be a little out of favor now in patients who aren't obviously at high risk. For example, someone who had a prior myocardial infarction, but more for the the primary prevention population in particular.
Right. Let's talk now about the paper that was the starting point for your editorial. 20 years ago, when we started talking about the need for improved prediction, was when the chronic renal insufficiency cohort study was started. And we used to talk about it as we need a renal Framingham. The starting point for your editorial was a paper from the CRIC group. The paper is entitled risk prediction models for atherosclerotic cardiovascular disease in patients with chronic kidney disease. The first author is Jay Bundy. So what did these investigators take on in this study?
So what they did was essentially they took the CRIC study, which, as you mentioned, is a longitudinal study of individuals with CKD, and then they identified a whole bunch of predictor or candidate predictor variables, roughly 50 of them, and set out to test whether they could use those to predict cardiovascular disease or events. And in addition, they compared those to the American College of Cardiology developed equations, which are one of the standard equations for prediction in the general population, but not a CKD specific equation. Both using the standard equation and one that they recalibrated specifically for use in the CRIC cohort, because as many of you us know, when you take an equation from the cohort where it's developed to a new cohort, sometimes you need to recalibrate the predictive variables in it to perform better. So they did all of that and found that the new equations that incorporated some of the variables in CRIC performed much better in the CKD population than the pooled chained equation. So suggesting that this would be a much better way or much better tool for predicting cardiovascular disease in the chronic kidney disease population.
You also describe in your editorial, you have a great figure talking about what are the steps. There's been reasonably good validation here on other cohorts, but nonetheless, to actually see this broadly implemented in clinical practice will require further assessment. What are the next steps? What has to be solved before this can actually move into general practice?
Yeah, I think I think this is an issue that as we have more and more ability to do this and to automate it, it's somewhat like the early days of when people were doing RNA array and could pick out all sorts of genes, but then the question is exactly what it means. I think we've gotten to a point where we're very good at being able to develop an equation that predicts something, and it can almost be automated with machine learning. I think the question is, if a tool that's not used isn't a very useful tool, and the equations that are published and developed may not be used for a variety of reasons. One of which we point out in the editorial is I think clinicians like to understand what they're doing, and they operate for better or worse by gut and intuition sometimes. And if something doesn't intuitively make sense to them, and that's often true of machine learning developed algorithms, it's very hard to convince clinicians that it's better than applying all their learning and knowledge to in clinical intuition. So I think one step is to simply do the public relations, as it were, of what's in an equation and why it should work. Ideally, hopefully the variables included make physiologic sense and aren't just mathematically predictive. I think that's one point. The second point is, quite appropriately, clinicians are reluctant to use prediction when it's not, when something hasn't been implemented in another setting and proven to work broadly. So Most often these equations are developed, in a particular data set. These authors did a pretty good job of trying to validate it, in a couple of additional data sets. But, I think that's another important step, is, not only validating it, but then implementing it, not in a research database, but showing that when you take it out of research and put it in the real world, testing whether the tool actually improves outcomes and or even works, in more of a real world setting where the data that you have might be imperfect compared to the quality of the data you gather in a more research and structured setting like CRIC. So I think those are some of the really important steps, sort of explaining what it's in there, and then both validating in other research data sets, which they did here, but then I think validating in real world practice, and showing not only that it improves prediction, but that something can improve outcomes is really important. And then I think the last step is, at least in this field, is that we have equations already, and the Framingham equation, for example, while it doesn't perform that well in CKD, people understand it. The pooled chain equations, I think people understand, although they're not quite as well known as Framingham. And I think an issue is also even the best tool or the best drug treatments, if they don't do a lot better than the standard that people are used to, it's often trouble to convince clinicians to begin using them. So I think, if there's a small improvement in AUC compared to the standard that's out there and that's well known across practice and not just to nephrologists, the trade-off in complexity of having a CKD specific tool may not be worth the implementation hassle to a lot of clinicians and the unfamiliarity. So that's, I think, sort of a general step that people need to be aware of when developing these equations, that a minor improvement in prediction, even if it's validated and even if you could implement it and show that it works better, there's a high hurdle to overcome in probably having to do much better than standards that are familiar and out there, even if they're not quite as good in a particular population. The trade-off in complexity may not be worth it.
Yeah, another setting in which prediction equations can be quite helpful is in the design of trials. Comments on that?
Yeah, I think, that's an area where I think there's been a lot of interest in the nephrology field in sort of predicting CKD progression per se, to better identify, the patients who are going to have outcomes and provide power for a clinical trial. And, we've used albuminuria and GFR, perhaps not in an equation form, but as predictive tools in trials, for quite some time now, but there's interest in doing better. There hasn't been as much attention paid to cardiovascular risk in the setting of CKD trials, at least not in terms of specific prediction tools. But I think, if you look at the Credence trial, for example, and some of the other SGLT2 trials, cardiovascular events have been quite frequently included in the endpoints.
Right.
And I think there's an opportunity to enhance the efficiency of our trials by using an equation like this to really identify the patients most likely to benefit from the intervention being tested. It's not worth testing an intervention in patients who aren't likely to have an event. So it may really enhance trials. And I think that's a setting where a complex equation that's only a little bit better and not that familiar to people outside of the field, but CKD specific, that's a place where there may be a lot of room and you don't have to worry about some of the implementation questions in quite the same way.
Right. The other point that you discuss in your editorial is that we're talking now about how well a single point in time assessment works, but we all know that kidney patients vary enormously in their progression rate, and so this may be something that really needs to be brought into prediction algorithms. Do you have comments on that?
Yeah, I think that is a point we really try to make, and I think no patients are static, but so that's a point that probably applies a little bit just to the general population. But I think atherosclerosis progression seems to be enhanced in patients with CKD in general, and moreover, the degree of kidney impairment can progress, and that may enhance progression further. So I think it's quite possible. If I'm a patient whose GFR was 60 a year or a year and a half ago, but it's 45 now, or my proteinuria has increased, my risk may be much greater now than it was a year ago.
Right.
And that's probably worth capturing, at our annual visits or semi-annual visits to help us reevaluate whether a patient, might benefit from a treatment now, whereas, they're studying a year ago, it didn't look like that. And I think right now, even the standard equations in the general population haven't really been set up to be repeated at frequent intervals, but it's probably worth thinking about that and trying to figure out how to validate equations for that purpose. It's difficult because you really probably need large data sets to reevaluate at frequent intervals like that, and have a good study design. But I think probably worthwhile and more coincident with the way we try to practice, or ideally should be practicing, is understanding what the patient in front of me needs now, as opposed to what they making a decision a year ago that's going to apply for 5 or 10 years into the future, even if the patient's changing.
I like your emphasis on the importance of real-world evidence for validation, but one piece of data that is often unreliable in EHR extracted data is assessment of proteinuria. And yet in good, rigorous cohort studies, it looks like a very solid predictor. Any comments on that issue?
Yeah, I think, I think we all know trials aren't real world, and I think we have to sort of operate on both ends of the spectrum. So we have to recognize where our practice isn't meeting standards that that should be achievable. I think better assessment of proteinuria is probably achievable, but at least in a nephrology practice, maybe less so. Medicine in general. But at the same time, I know in the case of CKD progression scores, people have tried to look at, how good does dipstick proteinuria work as a surrogate. Again, I think if the equation works fine in a cohort study, and maybe when we apply to a clinical trial where we can rigorously collect urine, there'll be a use for it. But sometimes the enemy of good is better, and, we might be better off developing an equation for proteinuria that's not first morning proteinuria, because that's how we're all tending to get it in practice. And, it may have a much greater impact and broader use if we develop an equation that, that's developed on the EHR data and the way proteinuria is collected there, because that's again, we might be able to get it in a nephrology practice and meet that
Right.
gold standard, but
Right.
we probably need tools that reflect what we do in practice.
Yeah. Okay. Well, David, I really appreciate your thoughts on this. So where do you think, what are the next steps when we think about risk assessment? What is not being looked at that should be, or how can we get better at this?
Yeah, I mean, I think the field is littered with a lot of predictive tools that never got used. I think we really need to take some of these equations and do the hard work. And I don't want to minimize it. I think it is hard work, but to do the hard work of implementing them in EHRs, or maybe taking a step back, doing trials to test their use, and then even implementing them outside of these kind of trials. But I think we really do need to do that, because otherwise it's an intellectual exercise. It's interesting, but ultimately we want to help patients. We need to take it to the next step, and if we can't do that, we probably ought to turn our attention elsewhere.
Right. Well, again, really thank you. I hope this conversation prompts our listeners to go and grab the March issue of Jason and read your editorial and look at this excellent paper. I think the Renal Framingham study is teaching us a lot of things, but the steps to actually turning this into a better outcome for our patients is complex and not easy. So thank you so much for participating with Jason in this excellent editorial and in this conversation.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.